Welcome back to the deep dive. We're here to really unpack the crucial stuff you need to know, not just for those big exams, but, for everyday clinical practice.
That's right.
And today we are tackling a big one, femur shaft fractures. Absolutely core knowledge for any ortho resident prepping for, say, FRCS or fellowship exams, or frankly, just wanting to be sharper on the floor.
Couldn't agree more.
And just so you know, our discussion today is grounded in the fantastic ortho-made simple notes you can find over at mokyingren.sg.
Ah, yes. Excellent resource.
They're put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, got his FRCS back in 2022. Really solid stuff.
Yeah, very practical notes. And femur shafts, well, they're not just a simple break, are they? Usually high-energy trauma.
Right.
Which immediately signals, potential polytrauma. You're assessing the whole patient, not just the leg. It's a systemic thing often. So our mission today, let's really pull out the key insights, flag those common pitfalls, and just nail down the management details you guys need. Turn that knowledge into real clinical wisdom.
Perfect. So let's jump straight in. High energy trauma rolls in. You suspect a femur shaft fracture. What is the absolute #1 thing you need to rule out, immediately? And why is it so critical?
Okay, yeah, this is rule #1, non-negotiable.
Yeah.
You must rule out an ipsilateral femoral neck fracture before you even really focus down on the shaft.
Ipsilateral neck fracture. Okay.
It sounds obvious, maybe, but it gets missed. And the incidence isn't trivial. We're talking around 10% of femur shaft fractures have one.
Wow, 10%. One in
Yeah.
10 cases. That's higher than I might have guessed.
It is.
Yeah.
And missing it. The consequences are, frankly, devastating.
How so? What are we talking about?
You risk things like a vascular necrosis of the femoral head, non-union of that neck fracture, chronic pain, serious functional problems down the line, potentially ending up needing a hip replacement. Just a disaster for the patient, especially if they're young.
Absolutely catastrophic.
And it's easy to get distracted, in that polytrauma setting. Everything's happening fast.
Yeah.
If they've had a CT TEP scan chest, abdomen, pelvis,
The standard polytrauma scan, yeah.
you have got to consciously, deliberately scroll down those images and look at the HEP. Make it a mantra.
Look at the hip.
Seriously. It often gets glossed over when everyone's focused on, say, bleeding or breathing.
Yeah.
But that missed hip fracture can ruin their functional outcome long term. Always, always have a high index of suspicion.
That's a golden rule right there. Look at the hip. Okay, so we've cleared that hurdle. No neck fracture. Now we need to categorize the shaft fracture itself. What's the go-to classification system residents really need to know inside out?
For shaft fractures, the workhorse classification, the one that really influences your treatment plan, is the Winquist classification.
Okay.
And it's not just academic, it's practical. It's all about the amount of comminution, how fragmented the bone is. That tells you about stability, how you'll fix it, even prognosis.
Right, so it actually guides your surgery. Can you break down the types for us? What does each one mean, practically?
Sure. Think of it as a scale of increasing combination and decreasing stability.
Okay.
Type Yo. This is your best case scenario. No combination. Simple transverse, maybe a short oblique. Good bone contact, inherently stable. Nailing is usually straightforward.
Nice and simple.
Type 1. Now you've got insignificant combination, maybe a tiny butterfly fragment, some cracking, but most of the cortex, the tube of the bone, is intact. Still pretty stable with the nail.
So good contact.
Type 2, getting more complex. Here you have greater than 50% cortical contact. So yeah, it's comminuted, but more than half the circumference is still touching. The nail still has decent bone to rest against.
Okay, some inherent stability left.
Type 3. This is a bigger step down, less than 50% cortical contact. Now the combination is pretty significant. That nail is doing almost all the work holding things together. Much less inherent stability.
So more challenging to get right.
Definitely. And finally, type 4. This is segmental with no contact. You got a whole piece or pieces floating in the middle, completely detached. Zero inherent stability between the main proximal and distal fragments.
A floating segment.
Yeah. Surgically, that's a whole different ballgame. You're fighting to get length, alignment, rotation. It's complex. Higher risk of problems like malunion or non-union.
So understanding Winquist isn't just about naming it. It really sets the stage for how difficult the surgery might be and what to expect. A type 4 sounds like a real challenge compared to a type 0.
Oh, absolutely. Night and day. A type 4 immediately signals unstable high risk, pushing you towards maybe needing extra tricks or adjuncts during fixation. It changes your whole game plan.
Very clear. Okay, let's shift gears to acute management. So before the OR, what sort of temporary traction might you use? And then let's tackle that big debate, reaming the femur, especially in polytrauma. That's evolved, hasn't it?
Right. So pre-op, for temporary stabilization in the field,
Yeah.
in the ER, the classic Thomas splint is still very useful. It's fixed traction.
Thomas splint.
Okay, helps control pain, reduces bleeding from the fracture ends, prevents more soft tissue damage, just keeps things relatively stable until definitive fixation.
Buys you time.
Exactly. Now, reaming, yeah, that was a huge area of concern for years, especially in sick, multiply injured patients.
Right. The fear of showering emboli, worsening lung injury.
Precisely. The worry was that reaming the inside of the bone, the medullary canal, could trigger or worsen systemic inflammation, ARDS, fat embolism, especially if they already had a chest injury. Big concern.
So for a while, the advice was maybe avoid reaming in those really unstable patients?
That was the thinking, yeah. Unreamed nails were often preferred in that setting, but the evidence has really swung things the other way now.
Okay, so what's the current stance? Do you ream in polytrauma?
The bottom line is, yes, you would ream, but with a crucial caveat. The patient has to be stable enough, meeting what we call early appropriate care or EAC criteria. And of course, they need to be suitable for nailing in the first place.
Okay, so yes, ream if stable. What evidence backs that up?
Two really key studies helped shift the paradigm. First, Boston colleagues back in 1997 did a big retrospective look. They found that reamed nailing in multiply injured folks, even with chest trauma, did not actually increase rates of ARDS, PE, multi-organ failure, pneumonia, or death. That was huge.
Wow, okay. That's pretty definitive.
And then the Canadian Orthopaedic Trauma Society, COTS, did a randomized controlled trial in 2006. Over 300 patients, randomized to reamed versus unreamed. They also found no difference in ARDS incidence.
So randomized trial confirming it, that's strong evidence.
Very strong. It gave surgeons the confidence to say, okay, reaming offers mechanical advantages, and it seems safe if the patient is physiologically stable enough.
Which brings us back to those EAC criteria. What are they? How do you know if the patient is stable enough?
Right. The EAC criteria are your physiological green lights. You're looking for pH greater than 7.25, base excess greater than -5.5, so less acidotic,
Right.
and lactate less than 4.
Okay. pH 7.25, BE, NaNH 5.5, lactate 4.
Those are the key numbers. And this isn't decided in isolation, obviously. You're working hand in glove with your ICU colleagues. They help determine overall stability. If the patient meets EAC, you can proceed with reaming and get the benefits: better fixation, potentially better healing. It's about balancing the fracture needs with the whole patient picture.
That's super important. Clear guidelines and evidence.
Yeah.
Okay, let's talk nailing itself. Definitive fixation. When do you choose retrograde nailing over the more common antegrade approach? And that question always comes up for residents. Does going retrograde through the knee mess up knee function?
Good questions. Retrograde nailing isn't the default, like you said. Antegrade is more common, but it has really specific, important indications where it's actually the better choice.
Like when?
You'd strongly consider a retrograde nail for bilateral femur fractures. Lets you manage both from one position, supine, no need to flip the patient. Huge advantage there.
Makes sense.
Also, for floating knee injuries, that's same-side femur, and tibia fractures, you can often use the same or nearby incision for both nails. Address the femur retrograde first. Simplifies things.
Right, streamlines the approach.
And the other big one is in severely obese patients. Getting to that antegrade starting point high up on the hip can be, well, incredibly difficult with a lot of soft tissue. Retrograde avoids that access challenge.
Yeah, okay. Practical considerations. So for those situations, it's a go-to. But what about that knee function concern, violating the joint? Does it cause problems later?
It's a totally valid concern. Intuitively, you're putting a nail starting point right through the knee joint, but the evidence is actually quite reassuring.
Oh, really?
Yeah, a key study here is by Dagler and colleagues, published in JOT in 2009. It was an RCT, 70 patients comparing antegrade versus retrograde. And they found no difference in functional knee scores or isokinetic strength testing at 1 year.
No difference at 1 year, even with strength testing.
Exactly. It was a really well-done study that basically showed that functionally, long-term outcomes seem equivalent. It tells us that if retrograde is the best mechanical option for the fracture, we shouldn't hold back just because of the knee entry point. Functionally, patients seem to do just as well.
That's really good to know. Dispels a common worry. Okay, let's tackle something more complex. Segmental femur fractures. Winquist type 4. What are the specific surgical challenges here? What do you need to be thinking about intraoperatively?
Segmental fractures. Yeah, these are definitely a step up in complexity. You got that free-floating middle piece, which makes everything harder.
Right, like juggling 3 parts instead of 2.
Pretty much.
Ah.
So surgically, a few key things. Positioning. Usually a traction table is essential to get length and rough alignment. But controlling that middle bit is the trick.
I can imagine.
Adjustments. You'll often need extra tools like a femoral distractor, clamps, maybe joysticks, to physically grab and manipulate those segments and hold the reduction while you're working.
So more hands-on reduction needed.
Definitely. The entry point for an antegrade nail can also be tricky. Because the proximal fragment often gets pulled into flexion and abduction by the muscles, finding that perfect starting spot on the greater trochanter is harder.
Right, the anatomy is distorted.
And this is critical.
Yeah.
The middle segment itself. When you're reaming, especially as the reamer head passes through that floating piece, you absolutely have to hold it steady during reaming to prevent it from spinning.
Why is spinning so bad?
Because that segment's blood supply is already precarious. If it spins wildly on the reamer, you can strip away any remaining soft tissue attachments, further devascularizing it. Big risk factor for delayed union or non-union of that specific segment. You got to protect its biology.
Wow. Okay, so don't let it spin.
Yeah.
Another key pearl. What about tricky patient situations? Like you mentioned traction tables, but what if the patient has a total hip on the other side? You can't just crank that leg up in a holder, right?
Exactly. Great point. That's a classic scenario where standard positioning is risky. Putting that contralateral THR hip into extreme flexion in a leg holder is asking for trouble dislocation, maybe loosening.
So what do you do then?
You adapt. Several options. You could try scissoring the legs on the traction table, keeping the THR leg more extended while still getting traction on the fractured side. Take some careful setup.
Okay.
Or you pivot your surgical plan. Maybe retrograde nailing in the supine position is the answer, as it avoids that contralateral hip flexion completely.
Right. Avoids the problem altogether.
Or even supine antegrade nailing, which could be done off the traction table, just on a regular flat-top table with manual traction, or maybe a distractor.
Supine antegrade.
Another option is lateral antegrade nailing, positioning the patient on their side. Again, different access, bypasses the traction table issue. It's about having these alternatives in your toolkit for when the standard approach isn't safe or feasible.
That's real surgical problem solving. Invaluable stuff. Okay, finally, let's talk about the complication everyone dreads. Femur shaft non-union. How do you systematically approach this? It can be such a difficult problem for patients.
You really can be. Non-union is tough, but you need a clear, stepwise plan. And step number 1, always, 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 is rule out infection.
Infection first.
Absolutely. Before you even think about changing hardware or grafting, you run the fracture-related infection, FRI protocol. Blood work, imaging, maybe aspirations or biopsies if needed. If there's infection, that dictates everything. Debridement, antibiotics, often staged surgery. You can't just ignore potential infection and expect bone to heal.
Non-negotiable first step. Okay, infection ruled out. What next?
That it depends a bit on the timeline.
Right.
At 3 to 6 months post-op, if healing looks slow, what we call delayed union, you might consider dynamization.
Dynamization, what's that involved?
It usually means removing the interlocking screws furthest from the fracture, typically distally, sometimes proximally, depending on the fracture pattern and nail type. The idea is to allow a tiny bit of controlled movement, micromotion, at the fracture site when the patient bears weight. This can sometimes stimulate the bone to heal, kickstart callus formation. It's a less invasive option to try first.
Okay, allow some controlled stress. And if that doesn't work, or it's clearly a non-union after, say, 6 months.
Right. If it's established non-union, you need more definitive surgery. Several options here. The classic is exchange nailing.
Take out the old nail, put in a bigger one.
Exactly. You remove the existing nail, ream the canal again, often larger this time, which provides a fresh biological stimulus from the reamings, and then insert a larger diameter, stiffer nail. Often very effective.
What else?
Other options could be removing the nail entirely and switching to plate fixation. Maybe the nail failed or the bone alignment isn't right for another nail. Or sometimes plate augmentation with nail retention. You leave the nail in place for intramedullary support and add a plate on the outside for extra stability and compression.
Okay, so several hardware strategies. What about the biology? Bone graft.
Yes, crucial point. Especially for atrophic non-unions where the bone ends look inactive, you almost always need to add bone graft. You need to bring in the building blocks and the signals for healing.
And where do you get the graft?
Autograft, the patient's own bone, is usually the gold standard. The iliac crest is a common source. provides good cancellous bone. Another excellent option, especially when you're doing an exchange nail, is using the Reamer Irrigator Aspirator, or RIA.
RIA.
Yeah, it's a system that lets you collect the bone debris generated during reaming. That debris is rich in bone cells and growth factors. You basically harvest graft while you're preparing the canal for the new nail. Very efficient. And uses the patient's own local bone.
Wow, that's clever, using the reamings themselves.
Exactly. So the approach is multifaceted. Rule out infection, optimize the mechanics, stability, and enhance the biology grafting.
That's a really thorough breakdown of a tough problem.
Yeah.
So, pulling this all together, what's the big picture takeaway for residents listening to this, prepping for exams, or just facing these on call?
I think the big picture is that femur shaft fractures demand a really systematic approach from start to finish. It's not just about knowing the steps, but understanding the why behind them.
Right.
Remembering that critical first step, rule out the neck fracture. Understanding Winquist so you can anticipate stability issues. Knowing the evidence behind reaming and polytrauma and applying those EAC criteria confidently. Choosing the right nail antegrade or retrograde for the right reasons, and not being afraid of retrograde when indicated. Having strategies for those complex segmentals, like protecting that middle piece, and then having a robust, stepwise plan for non-union, always starting with infection. It's about connecting all these dots. The knowledge is only powerful when you can integrate it and apply it effectively, especially under pressure.
Absolutely. It's about building that solid framework for thinking through these often complex injuries. Well, we've certainly taken a deep dive today, from that initial assessment all the way through to managing long-term complications like non-union. Hopefully you listening now have a much clearer picture. And again, a big thanks to the OrthoMade Simple Notes from mokyingren.sg for providing such a great foundation for this chat.
Definitely a valuable resource.
So, to leave you with something to chew on, we talked about EAC criteria for deciding if you can operate early. But thinking even earlier, right after the injury in a polytrauma patient, how might their initial physiological state, maybe even before they strictly meet EAC, influence your very first thoughts on fixation timing and maybe even the type of temporary or definitive fixation you choose, specifically thinking about preventing early complications like compartment syndrome or DVTs? Just something to mull over. Thanks for joining us on the deep dive.